Good morning, everyone. Thank you for joining with us with another academic session. Today's topic is on common gastroenterology conditions. It's been conducted by Dr. Supun Kulatunga, consultant gastroenterologist, NHSL. Dr. Supun obtained his MBBS from University of Colombo in 2008 and completed his MD at the Postgraduate Institute of Medicine in 2016. So without any delay, let me invite Dr. Supun to commence the lecture. Thank you.
Good morning, everyone. Thanks, Ranesh, for the kind introduction. Okay, so today I'm going to talk about common gastroenterology presentations at primary care level. So I need to this is a bit of a vast topic, so I won't be able to address each and every condition in detail, but I would like to focus more on functional conditions because due to the economic problems of the country in the past few years, we see a lot of anxiety and stresses among people, which has increased the functional conditions in the public. So we see more and more referrals are coming to our gastroenterology clinic. Sometimes it has become a burden for our clinics as well. Clinics are flooding with functional patients. So I'm going to focus more on these presenting symptoms: dyspepsia, bloating, reflux, abdominal pain, cramps, constipation and diarrhea. So I will not go into minor details with definitions and all, but I will try to cover what are the important things in primary care level. Right, so going into dyspepsia, this is, I think all of you know, this is a common term which is used for collection of symptoms, basically symptoms arising from stomach and the duodenum. We call that as dyspepsia. So there are collections of different symptoms like epigastric pain, burning sensation, bloating, belching, and nausea. So for all of that, we use the term dyspepsia. So in our Sri Lankan setting, in the primary care level, patients used to come and say, I have gastritis. Doctor, mata gastritis wage. That is what our patients used to say. So it's very vague. Therefore, it is our duty to ask specific questions to figure out what is the predominant symptom in these patients. Otherwise, all of will come and say just gastritis. So, gastroesophageal reflux disease, commonly known as GERD, it is not a typical symptom of dyspepsia, but those two conditions can coexist. Vomiting is a bit atypical in dyspepsia. If a patient's predominant symptom is vomiting, then it warrants to investigate further whether there is any underlying pathology. Out of the people presenting at our primary care level, 70% of the patients are having functional dyspepsia rather than organic etiology. So I think, but I don't know whether we are taking enough time to take a detailed history to differentiate these two entities. So this is basically the common causes of dyspepsia. So basically we have organic dyspepsia and functional dyspepsia. So organic means we have there's a pathology that we can investigate and we can find out. So its common ones are peptic ulcer, gallstone disease like and esophageal conditions, pancreatic conditions, biliary conditions, and things happen secondary to medication use, and there are functional aspects as well like IBS and anxiety, depression, which leads to functional. So moving on to the pathophysiology of dyspepsia, in literally acute gastritis means inflammation of the lining of the stomach. So there are direct irritants to the stomach like a certain type of food with more citrus content, and medications, smoking, alcohol, There are direct irritants to the stomach lining which cause acute gastritis. But apart from that, there are conditions which will alter the neuronal pathway between the brain and gut, which we call at gut-brain axis. So when there is disorder in gut-brain neuronal pathways, there will be problems in motility and distension and constriction of the stomach. In terms we call fundic accommodation and antrum distension. So with this disorders of gut-brain axis, there will be symptoms more of a functional origin, and if there are changes in the gut permeability, and if there is changes in gut microbiome, then those also can lead to functional dyspepsia. So functional dyspepsia, in simple terms, it's a dyspepsia without obvious cause. Earlier it was known to as non-ulcer dysplasia. So it's fairly common in our communities. So it's like 80% people will be diagnosed having functional dyspepsia after upper GI endoscopy. So this is a fairly new term, DGBI, that is disorders of gut-brain interaction. So these are still poorly understood, but more day by day knowledge about this getting increased. So if there is a disorder between this gut and brain neuronal axis, there will be a lot of motility disturbances, and there will be visceral hypersensitivity. So even the slightest movement, the patient will perceive it as a pain, so which ultimately become symptomatic and present as dyspeptic symptom. So in other than that, there will be immune and mucosal dysfunction, problems in gut microbiota, and altered signal pathways and central nervous system processing of signals from the gut. So this is basically the definition of functional dyspepsia according to Rome 4 criteria. So there are main 4 symptoms we are focusing on here. That is epigastric burning sensation, epigastric pain, and postprandial fullness and early satiation. So out of these 4 questions, the symptoms onset should be at least 6 months back and active symptoms for 3 months, with no evidence of structural disease from upper GI endoscopy. From this criteria, we will be able to diagnose functional dyspepsia. Based on the predominant symptoms, we classify functional dyspepsia into 2 subcategories. That is postprandial distress syndrome, PDS. Predominant symptoms will be postprandial fullness and early satiation. And the second subtype is epigastric pain syndrome, predominantly with epigastric pain and epigastric burning. So these are the main 2 subtypes of functional dyspepsia, and the management and the neuromodulator drugs that we use will be slightly different in each category. So how to assess dyspepsia in the primary care level? I think the key is history. So we need to spend a bit of more time with the patients, taking a detailed history. What is the predominant symptom? What are the associated symptoms? And how long the duration? And whether it is resistant to treatment, or whether there are any recurrences, whether it is related to meals. All these things are important. And the one thing I need to highlight is the cardinal or the alarming symptoms, which warrants urgent further investigations and referring to a specialist care. I will later discuss what are the alarming symptoms when it comes to dyspepsia. So other important things which we need to ask in the history is whether there is a family history of GI malignancy, inflammatory bowel disease history, celiac history. And if you spend more time with the patient, they will come out with the anxiety, stress, any things which can trigger functional dyspepsia. And whether there are any recent take of painkillers, NSAIDs, like and any antibiotic use, which can trigger dyspepsia. So these are the alarming features when it comes to dyspepsia. So the age is bit tricky according to the guidelines. So I base this presentation on BSG and NICE guidelines. So those are in a Western setting with a lot of facilities. So the age sometimes some say it's like more than 50, some say 55. So age is one thing, and if there is unintentional weight loss with dyspepsia, definitely without age category, dysphagia or dinophagia, anemia, any evidence of gastrointestinal bleeding with melena, hematemesis, any palpable masses, lymphadenopathy, sudden onset of symptoms and progressive in nature, persistent vomiting, family history of upper GI cancer. So these are alarming symptoms which you need to send the patient for further investigations or to a specialist care center to further investigate. So this is just example. In the NICE guidelines, they say if a patient more than 55 years having dyspepsia with weight loss, that patient needs early. That means within 2 weeks, the patient needs an endoscopy. And they also mention patients more than 55 years of age with treatment resistance or either have vomiting or nausea. They need endoscopy, but not urgent, but early endoscopy. They specifically mentioned about raised platelet count. So the reason is a study done in UK, over 40,000 patients, they found out that there's a close relationship between upper GI malignancy and high platelet count. So the raised platelet count has mentioned in different guidelines. So this is the same thing I told you about, alarming symptoms and when to suspect gastroesophageal cancer. Basically, the things I mentioned is already here. It's like a repetition. So primary care level, so if the patient is having alarming symptoms, refer to a specialist center, at least for upper GI endoscopy. Then if the endoscopy does not explain patient's symptoms, we can further investigate the patient with imaging. In our setting, at least with an ultrasound scan of the abdomen. If possible, it's better to have a contrast enhanced CT. And we can easily check Helicobacter pylori stool antigen, but make sure to off PPI, off medication for at least 10 to 14 days. Otherwise, there's a high chance for negative results. And basic investigations, full blood count, we can say whether there's thrombocytosis, anemia, and inflammatory markers like CRP, ESR, which warrants more inflammatory pathology in origin. So always, if a patient presents with dyspeptic symptoms, just keep in mind whether there's a chance of Crohn's, whether there's a chance of biliary pathology, whether there's a chance of pancreatic pathology. Because there are many instances that patients has been treated repeatedly for gastritis while they were having pancreatic pathologies. Other thing is, if a young patient comes with dyspepsia with treatment resistant or recurrent, always have the suspicion whether there's any underlying Crohn's disease. Functional dyspepsia can overlap with other functional disorders, especially with IBS, irritable bowel syndrome. So one key feature you can differentiate is whether to ask about the association with defecation, whether there are like abdominal pain which relieved by defecation or incomplete evacuation. So IBS always goes with defecatory problems. And if there is GERD, reflux disease, then there will be radiating pain from epigastrium towards throat, and they will feel that acidic contents coming to the throat or mouth. And there are other conditions as well, like functional diarrhea, constipation, and bloating. Right, so management in dyspepsia in the primary care level. So basically, I think we discuss what to investigate and when to refer a patient to a specialist center. So first thing is lifestyle modifications with diet, exercise, and stress management. So diet, we need to decrease the food with high fat content and with high carbohydrate and yeast content, and engage the patient in more aerobic exercises, especially citrus food, food from the onion family, and food contain a high amount of chemicals with artificial dyes, chemicals. They trigger functional dyspepsia. And also we can test for H. pylori and treat for that. And sometimes existence of H. pylori may not be the cause of functional dyspepsia, but if it is positive, better to eradicate the bacteria. From the medication wise, first line treatment will be H2 receptor blockers, famotidine, vanitidine with PPIs. So we can either combine, or we can start one and go for another. And if the patient is not responding properly to this treatment for 2 to 4 weeks, then we can add gut-brain neuromodulators, that is tricyclic antidepressants. We can start with a lower dose of 10 milligram at night. The common ones we have is amitriptyline. So that is the point. I think we need to, if the patient is not responding, then we need to refer the patient to a secondary center for further evaluation and other management. So I mentioned earlier there are 2 subcategories of functional dyspepsia. So epigastric pain syndrome responds well with tricyclic antidepressants, while PDS, postprandial distress, responds well to mirtazapine and buspirone and to pregabalin. Right. So this is basically the same thing in graphical way. So that's basically about dyspepsia. So what I need to tell is, so in our primary care level, presentation of functional dyspepsia is very frequent. So you need to ask specifically about alarming symptoms, and if it present, refer the patient to at least upper GI endoscopy or to a specialist center. Right. So next we will move on to the next symptom, that is bloating. Bloating is a sensation. So sorry for the busy slide. It's a sensation that a patient feels with the intestinal gas. So bloating and distension is different. Distension is like an objective increase in abdominal girth. Bloating is the sensation of gas and the discomfort that patient feels. So it's very common symptom in all categories, and bloating is more common with IBS, functional dyspepsia, and other functional FGIDs, means functional gastrointestinal diseases. Right, so moving into the pathophysiology. So again, it can be problems with the gut microbiota, and maybe overgrowth of gut bacteria, which we call as SIBO, small intestinal bacterial overgrowth, gas accumulation and problems of gas handling and gas transit in the intestines, problems of abdominal and diaphragmatic reflexes, visceral hypersensitivity, and fermentable carbohydrates in the system. And one important thing is constipation, which is a very common condition which cause bloating, and again stress, anxiety, and sometimes, especially in females, they get bloating with their menstruation. So this is again the same thing. Functional bloating. So again there are criteria. So it's like bloating onset is like 6 months, and active symptoms are there for 3 months. And important thing is if the patient does not fulfill the criteria for IBS, so then it goes more towards functional bloating. So, assessment of bloating and treatment. So again, we need to take a good history and change the dietary patterns, increase aerobic exercise, and treat if there is underlying constipation, especially in a female who is having bloating. At least check ultrasound scan pelvis to exclude ovarian pathologies, maybe a tumor marker of CA125. For the treatment, there is not much of a place with proton pump inhibitors or H2 receptor blockers here, but prokinetics has a place, and probiotics which will change the gut microbiota, and antibiotics, especially for SIBO, small intestinal bacterial overgrowth. We can use antibiotics like rifaximin or metronidazole, ciprofloxacin. Those will change the gut microbiota, and it's proven to get relief of symptoms with the antibiotics. And antispasmodics, especially mebaverine, alvarine, they will relax the bowel smooth muscles, so the sensation of bloating will be relieved. And gas reducing substances like semethicone, the patient will benefit. And failing all that, like in functional dyspepsia, we can use tricyclic antidepressants and SSRIs as well. So it's like amitriptyline, and from the SSRI there are escitalopram, which is commonly used for these conditions. So next symptom I would like to discuss is gastroesophageal reflux. So this can coexist with functional dyspepsia. So the differential diagnosis of heartburn, GERD, maybe it's a dysmotility of the esophagus. So it can be either achalasia or can be esophageal spasm. There can be candidiasis, especially if the patient is on inhalers. So if they don't have the practice of clearing their mouth after use of inhalers, they have the tendency to develop candidiasis in esophagus. So eosinophilic esophagitis, it's another condition. And especially if someone comes with chest pain, heartburn, please ask about this exertional angina, because there are many instances that treated as GORD, ultimately the patient had angina. And there's an entity called functional heartburn, and there's also a chance to have a esophageal malignancy. So basically, in simple terms, GERD means reflux of stomach contents into the esophagus causing troublesome symptoms. So there are typical symptoms and atypical symptoms with GERD. Typical symptoms are heartburn, chest pain, and regurgitation. So, the relationship with belching and reflux disease is variable, but belching can be a part of reflux pathophysiology. And sometimes these GERD patients have chronic cough and wheezing. In the absence of typical symptoms, hoarseness, globus, nausea, abdominal pain have a low likelihood for the relationship between GERD. So there's a few points. Regurgitation needs to be differentiated from rumination. Rumination is actually the patient unconsciously brings up the food, but regurgitation, the pathophysiology of is somewhat different. And there's an entity called supragastric belching and gastric belching, that is involuntary bringing air inside the esophagus and putting it out. And gastric belching is like putting the air out from the stomach. So these two conditions, sometimes these start as a stress reaction, these belching start as a stress reaction, but later it become a habit. So as mentioned here, belching can be a part of behavioral syndromes without pathological reflux. Right, so GERD, so gastroesophageal reflux disease. So if a patient presents with symptoms of GERD, we can treat symptomatically. The aims of treating is to heal if there is any if there is esophagitis, and to prevent stricture formation with esophagitis, and to prevent from Barrett's esophagus, which is the changing of the lining of the stomach, which can lead to dysplasia and sometimes can lead to esophageal carcinoma. So the treatment basically based on lifestyle modifications and control gastric acid secretion through medical therapy with antacids and PPI. So when it comes to lifestyle modification, these are the things that we can do. If the patient is overweight, the best thing would be to advise the patient for the weight reduction and avoid substances which can trigger reflux, which will relax the lower esophageal sphincter. It's alcohol, chocolate, citrus fruits, tomato-based products, peppermint, coffee, and vegetables in the onion family. So you can advise the patient to have a trial, like avoid the food like for 2-3 weeks and see whether it makes any difference in the symptoms. So it's like you can ask the patient to keep a food diary. So then the patient will be able to figure out what are the things which will worsen his reflux. So food diary is a good thing. And second thing is because you can't ask the patient to avoid a lot of food items at once. So you can pick one food item and ask to omit it for 2 weeks and see whether it makes any difference. So if it doesn't make any difference, then that may not be the reason behind his worsening of reflux. So you can likewise choose one item for like 2 weeks. Other thing is avoiding large meals. In our setting, our people used to eat heavy dinners and they go to bed just after having a heavy dinner. So this is one thing which will worse symptoms and can make matters worse. And you need to ask the patient to take at least 2 to 3 hours, stay in a seated or upright position without lying down after a meal. And one thing is ask the patient to keep the head end of the bed at least about 8 inches. That means about 10 to 15 degrees angle. You can set the bed at an angle and sleep. These all will lower down the symptoms. Pharmacological therapy, I think, is nothing new, like antacids, H2 receptor blockers, proton pump inhibitors, and prokinetics. So if the patient is having recurrent symptoms and poorly responding to treatment, so that is the time for you to refer for upper GI endoscopy to have, and for specialist care to do pH studies whether the patient needs surgery. So this is same thing again. So right. So next one, I would like to move on to abdominal pain and cramps. So there are loads of etiologies. So I'm not going to detail in very clear-cut etiologies. I would like to talk a little bit about irritable bowel syndrome here, because that is what are we having common in our settings. So irritable bowel syndrome is a very common condition. It's again a disorder of gut-brain interaction. So again, the pathophysiologies are alteration of gut microbiota, visceral hypersensitivity, and problems in the neuronal pathways, immune modulation and inflammation, changing the permeability of the gut wall. So basically, for all the functional diseases, the pathophysiology remains more or less same. So these are common symptoms of IBS. Typically, IBS is related to defecation, as I told you earlier. It can be either constipation, it can be diarrhea, or it can be mixed. There will be changes in consistency of stool and also the frequency. So you will find they will tell more about mucus in their stools, and there is sensation of incomplete evacuation. That's again very common symptom. And the patient will have abdominal pain and cramps. Most of the time the pain and discomfort will relieve with defecation. That is a bit of a classic symptom to IBS. So again, there's a specific diagnostic criteria for irritable bowel syndrome, ROM 4. It says recurrent abdominal pain on average at least 1 day per week for at least 3 months associated with the following, which is related to defecation, associated with change in frequency of stool or change in the form, the consistency of stool. So the onset should be like 6 months back, and active symptoms should be there for at least 3 months. So the problem with IBS is the symptoms of colorectal cancer and inflammatory bowel disease. The symptoms are more or less same. So therefore, it is a bit challenging to diagnose IBS without any proper investigations. But these are the alarming symptoms when it comes to suspected colorectal cancer. So again, it unexplained weight loss with abdominal pain, unexplained rectal bleeding, and iron deficiency anemia, sudden change in bowel motions, positive fecal local blood, and probable criteria are abdominal or rectal mass, and I will go into detail again. Right, so these IBS again, it's more to do with what you call defecation, stool consistency, and frequency. But there are a lot of overlaps with IBS. As I mentioned earlier, functional dyspepsia can be overlapped. There can be functional constipation and bloating as well. So according to the stool type, IBS can be classified into another 4 subtypes. So this is on your left of the screen. It is called the Bristol stool chart. According to the consistency, the form, it can be divided into 7 categories. Type 1 is separate hard lump-like stools, and type 7 is entirely liquid stools. So there will be a range from type 1 to type 7. So this is, you can easily download this from internet, and you can use it in your common practice at your levels. And there are 4 subtypes of IBS: IBS-C, IBS-D, IBS-M, and IBS-U. IBS-C means it's constipation predominant. So more than hard or lumpy stools 25% of the time. IBS-D means diarrheal predominant. So it's 25% of the time it's loose stools. And there will be mixed type, that's called IBS-M, and if it doesn't fall into any other, it's IBS-U. Right, so functional gastrointestinal disorders such as IBS are far more common in our practice, but always remember colorectal cancer and inflammatory bowel disease, because the symptoms can be somewhat similar. But then you need to take proper history and look for alarming features of colorectal cancer or any serious sinister pathology. So in IBS, usually there are extraintestinal symptoms like back pain, bladder and gynecological symptoms, may be associated insomnia, and functional somatic disorders like fibromyalgia, tension headache, chronic fatigue, and these people will have like somatoform type behavior. So I think it's they have the common tendency for doctor shopping, so they will go from place to place, even though how much you try to convince them this is functional. So you need to have a good doctor-patient relationship when managing IBS patients, right? So diagnosis of IBS in the primary care setting. So again, detailed history. Always look for alarm symptoms and signs. Do abdominal examination, see whether there is any palpable lumps. Digital rectal examination. This will help to see whether there is any rectal masses, as well as identify dysenergic defecation. That means with straining there will be tightness of the sphincter. So that is again a problem of IBS-C. And do basic investigations with inflammatory markers. See whether there is any changes towards inflammatory pathology. And fecal local blood and fecal calprotectin, especially the age is less than 45 years. So the problem is in our setting we get the fecal calprotectin as negative or positive, but fecal calprotectin can be positive in any inflammation in the bowel or colorectal cancer, any bowel infection, it can be positive. We can get a titer of that, so that's a disadvantage. If it's a female, always do pelvic ultrasound to exclude ovarian pathology and tumor marker CA125 to see whether there's a tumor, ovarian tumor. Right, so we will be able to make a positive diagnosis IBS based on symptoms. Specifically, if there are no alarming symptoms, there are no rise in inflammatory markers, and there is no change in his basic investigations. So, but always if you are in doubt and if the patient insists, make sure to refer for further investigations and for specialist care, because symptoms are similar with inflammatory bowel disease and sometimes with colorectal cancer. So this is again basically the management pathway. So when to do a colonoscopy in irritable bowel disease. So if there are alarming symptoms or signs, you need to refer the patient for a colonoscopy. And if it is more diarrhea predominant, then again it is justifiable. And if there are atypical features, if there is suspicion of microscopic colitis, especially with female sex and age more than 50 years, coexisting autoimmune diseases, and if patient has severe or nocturnal symptoms, watery diarrhea, and if the diarrhea is there for more than 3 months, and those are the things which justifiable sending patient for a colonoscopy further evaluation. So the treatment of IBS, again, like in all other functional disorders, it's a good doctor-patient relationship is very important in this, because sometimes these patients, even though they nicely fit into the IBS diagnostic criteria, they do not like to accept the diagnosis. So they always think that as doctors we have missed something. So they always want to do more and more investigations and go from center to center. So that is the nature of their functional behavior sometimes. So good doctor-patient relationship is important if you need to continuously treat these patients. So you need to advise to have regular aerobic exercises, to dietary therapies with low FODMAP diet, So, and especially the diet rich in soluble fibers. Probiotics has a place in IBS, and if the patient is having IBS-D, diarrhea predominant, we can use loperamide to control the symptoms, but loperamide will not improve the global symptoms of IBS. It will just reduce the frequency of passing stools. But on the other hand, antispasmodics, that is mebeverine, alvarine, that class will relax the smooth muscle in the colon, so the patient will feel improvement of the global symptoms. And failing all that, or with the above things, we can start the patient on gut-brain neuromodulators, that is low-dose tricyclic antidepressants, amitriptyline. We can start with a dose of 10 milligram and gradually increase it up to 25, or sometimes it can go up to 50 even, and can try SSRI, citalopram, escitalopram. So always, if in doubt, better refer to a specialist center, and if there are alarming signs, better send for further investigations. So this is basically the same thing in a graphical manner. So I am not going to further details since we are running out of time at the moment. So another important entity that I like to talk about is inflammatory bowel disease. So symptoms may be similar with IBS. So there are patients who have similar symptoms with IBS, like cramping, irregular bowel habits, passage of mucus without blood or pus. So it's like symptoms wise it's same as IBS. So because of that, there will be delay in diagnosis of IBDs. But if you ask specific symptoms like systemic symptoms, IBD patients will come out with systemic symptoms, especially fatigue, and they will have weight loss, fever, night sweats, malaise, arthralgia. So extraintestinal side effects, systemic symptoms are common with IBD, especially weight loss, fatigue. So diarrhea, it can be mucoid diarrhea or can be bloodstained in stool. So there may be one important thing is patients will have nocturnal symptoms, and sometimes there may be urgency and incontinence. Constipation also can be a feature of IBD, especially with ulcerative colitis. And there will be bowel movement abnormalities like painful defecation, urgency and tenesmus, and there can be associated abdominal cramps and pain. Especially patient will have right iliac fossa pain in Crohn's disease, and periumbilical and left lower side pain in ulcerative colitis. But these are not hard and fast, things can be vary. Nausea, vomiting is more in Crohn's disease than in ulcerative colitis. So investigations, we can start with basic investigations and see whether there is any changes in full blood count, whether there is anemia, leukocytosis, thrombocytosis, elevation of inflammatory markers, CRP. But just remember, there are significant number of patients with Crohn's or ulcerative colitis with no rise in ESR or CRP. So there can be still a possibility of inflammatory bowel disease without high ESR and CRP. Fecal calprotectin is a useful investigation. If it is positive, we can go into further investigations. But unfortunately, we are not able to get a titer. Therefore, we can't get a specific number, specific value with calprotectin here. And another few things we can do is stool full report and exclude Clostridium difficile infection if there are any recurrent use of antibiotics. So the next thing I would like to briefly discuss is constipation. So the constipation can basically divide into, there are different categories, divisions, but there are primary and secondary. Primary constipation is like functional constipation. Secondary is always secondary to a medication or systemic illness. So these are the common causes of constipation. Secondary and primary all together are here. So medications, lack of exercise, not enough liquids taken, and not enough fiber content in the diet, IBS, and suppressing the urge to open the bowels. So when it becomes chronic, it can lead to constipation. So changes in lifestyle, like travel, pregnancy, and life events, those things can trigger constipation. Anorectal disorders, dysenergification, and malignancy, IBD, those also have a tendency to present as constipation. So again, functional constipation can be divided into three categories: slow transit, normal transit, and outlet constipation. So the outlet constipation is similar to pelvic floor dysfunction. So we don't have much of facilities to do a colonic transit study. So just for the theory, I add this slide. So these common conditions for secondary constipation, especially we need to ask about these calcium channel blockers, tricyclic antidepressants, NSAIDs, diuretics. They all can lead to constipation. And from the medical conditions, diabetes, hypothyroidism, IBS, hypercalcemia, again a few causes of secondary constipation. So what are the indications to do endoscopy in constipation? So the first two things will be not very related, but change in the stool caliber, if it is blood positive in the stools, iron deficiency anemia, obstructive symptoms, rectal bleeding, rectal prolapse, unexplained weight loss, these all warrants for a colonoscopy. So this is the basic outline of management of constipation. So the first line would be bulk forming laxatives, that is aspergillus husk. So we can start with bulk forming laxatives, and failing that, we can move on to the second line one, that is osmotic laxatives, that is polyethylene glycol, in other words macrogol, either combining with a stimulant laxative like bisacodyl. So we can try a combination of these for few months, and in the meantime we need to ask the patient to changes his lifestyle with dietary modification, increase water intake, engage in regular physical activity, and failing all that, and if there are symptoms, as I mentioned earlier, then a patient needs to be referred to a specialist care for further investigations, or to start other medications. So trucalopride is a medication which we use for constipation. It's available here, but we don't have linaclotide at the moment. Right, so the last subtype I need to discuss is chronic diarrhea. So chronic diarrhea is again one of the most common reason patients refer to gastro clinics. So there can be overlap with other conditions as well. So the diarrhea can be results from colonic neoplasia, or from inflammation of the colon, infection, small bowel inflammation, and malabsorption due to pancreatic pathology, or due to motility disorders. So the symptoms suggestive of a more organic origin is if the diarrhea is more than 3 months duration, and if it is continuous without intermittent, and if the patient is having more nocturnal symptoms, and if there is underlying significant weight loss. So these are the basically the etiologies for diarrhea. So the history is again important when evaluating diarrhea. Ask about a family history of GI malignancies, IBD or celiac disease. Is there any recent travel, past surgery, especially cholecystectomy? Because in past cholecystectomy patients, they have bile acid malabsorption, which can trigger diarrhea. Any history of pancreatic disease, especially chronic pancreatitis, which can lead to malabsorptive type of diarrhea, excess alcohol consumption, and systemic illnesses like hyperthyroidism, and certain drugs, especially like proton pump long-term use of PPI, metformin. They also trigger chronic diarrhea, and anxiety and depression can have diarrhea as well. So always not to forget alarming symptoms in the case of diarrhea. So investigations, again, the aim is to not to miss colorectal cancer or inflammatory pathology. So start with basic investigation, check whether the patient is having anemia, any leukocytosis, thrombocytosis, whether there's any raised inflammatory markers, or there are any features of malabsorption like low albumin, any changes in electrolytes, other associated deficiencies of nutrients like vitamin B12, folate, any abnormality in thyroid functions, whether have the suspicion of hyperthyroidism, Clostridium difficile toxin, celiac panel. So I think the celiac panel is a bit expensive in our setting. That's a practical problem of having that investigation. And from the blood investigations, you can do stool investigations like fecal calprotectin and stool focal blood. From that, we will be able to see whether there's any underlying pathology behind these patients' presentations. So again, alarming features, blood in stools, more than 10% unintentional weight loss, nocturnal symptoms, fever, new onset of symptoms after age of 50, and family history of colorectal cancer, inflammatory bowel disease, and celiac disease. So that's basically the outline I'm planning to give. So as a summary, I would like to say that functional gastrointestinal diseases are very common, and so you don't need to refer each and every patient for the secondary care, because overloading secondary care with functional patients will become a problem there. So when doctor-patient relationship is very important when managing functional patients, and take a bit of more time and take a detailed history if somebody presenting with especially dyspepsia and other conditions. Check for alarming features, red flag signs, which your history taking will not delay sinister pathology. So that's very important to rule out alarming features. And if there are alarming features, refer to a secondary center, specialist center at the appropriate time, rather than recurrently treating with the same thing for a long time, which will delay a sinister diagnosis. So these are the basic things I would like to emphasize you on regarding the common presentations at primary care level. Right? Okay. So thank you very much for listening to me.
Thank you so much, sir, for enlightening us with that very informative lecture. Sir, there's one question over here. They're asking, omeprazole, can we use it in CKD patients for long term?
The thing is like long term, why we need to use it? That's the question. Why we need to use omeprazole on CKD patients? So it depending, you can use, but so we have come across that that proton pump inhibitors are one of the class of drugs which is highly abused. Like once it started, it's going on for ages and ages. So rather than continue omeprazole for long time, better to, as I mentioned, better to see, better to look for why you have to use omeprazole, whether there is any underlying problem. So that's what I need to say, because that's why I need to highlight, even because rather than continue things, better to look for any other secondary causes, especially in CKD with their uremia. They have a lot of changes inside their stomach lining. They have hemorrhagic gastritis, so there are what you call a group of patients which these conditions are more prone. But always better to have an endoscopy and see whether they are missing something.
So there's another question in par with that specific question. They're asking, recent onset, we have noticed patients take omeprazole when they have gastric pain. Even quacks keep on prescribing omeprazole and domperidone time to time when symptoms appear. What do you recommend, and how long we should prescribe medicine without investigations? When to search specialist care?
So I don't know how to deal with quacks and things, but when you start a patient on proton pump inhibitor especially, so you can continue it for like 4 to 6 weeks at a stretch. But I don't recommend like going it for months and months, unless you can use it for like 4 to 6 weeks and then see whether there's an improvement, right? If the patient is getting recurrent, then better to check rather than giving omeprazole for months and months, right? So always take a detailed history. There may be some precipitating factor why the omeprazole is not responding. Even if you are giving omeprazole, say like if there are any food item that patient is taking which will irritate the stomach, so once you give the omeprazole, it will settle the problem, since the patient is continue to take that food item or the drug, so the problem doesn't go away. So always, because this gastritis is relatively a literal term, like inflammation of the lining of the stomach, so there should be some irritant to the stomach. So either it's a drug, or it's a food item, or it's a Helicobacter pylori. There should be or the psychological stress or anxiety. So if somebody is not responding properly to omeprazole, then we need to dig a bit deeper why it is not responding. Most commonly, it's maybe a food item or something that patient takes. Especially there are a lot of chemicals in our diet at the moment, and the patient sometimes does not come out with the things that he eat, right? So I think that.
So there's another question. Can you explain how odynophagia considered as an alarming symptom in dyspepsia?
Odynophagia is like painful swallowing. So what ask?
He's asking why odynophagia is considered as an alarming symptom in dyspepsia.
Because it can be underlying malignancy. So that in most of the guidelines it say, irrespective of the age, if somebody comes with dysphagia and odynophagia, always investigate further. It's alarming because it's painful, because we don't know why, because even a chronic thing will appear as acute problem. So it will start as odynophagia, maybe later turn into dysphagia. So because with those conditions, better not to take chances. That's what I am saying. So because unless it's a motility, esophageal spasm or something, better to see whether there's any esophagitis, whether there's any esophageal cancer. Maybe there may be something if somebody comes with odynophagia, unless it's a very stressful condition causing an esophageal spasm.
So that's all with the questions, and thank you so much, sir. I think you've opened our eyes to a different set of questions, and thank you for that informative lecture and for the Q&A session. So shall we conclude the session for today, and we'll meet you back with another session in 2 weeks' time. Thank you.